Few things stimulate emotions and debate, campaigners, activists, and local politicians more than A&E. And that is because there has been a steady and relentless growth in demand for our accident and emergency services. For the winter of 2012-13, we established what were called accident and emergency tripartite groups, which in the new structures of the NHS brought together the Trust Development Authority, Monitor, and NHS England to try and identify and solve local problems. By 2013-14, it had become clear to us that we needed to engage more people than just those in the debate, and we established what were called urgent care working groups, which were subsequently to go on to become system resilience groups that would bring together commissioners, providers, and anybody else who have an interest in urgent and emergency care. So this year, we've started to address winter much sooner. So in January and March, we held a number of workshops. In April, we published our flu plan. In June, we published our operational planning capacity guidance. At the same time, the Secretary of State announced £400 million to be put into the system. In October, a further £300 million was put into the system with a view to addressing issues of staffing and bed capacity, not just in acute hospitals, but also in community services. But meantime, other things have been going on. We're caught in the NHS in the quadruple pincer of increasing demand, escalating costs, rising patient, public and professional expectations in a tightened fiscal environment. And that's coupled with some pretty dramatic demographic changes. So we now have more older people than younger people in this country, and older people suffer from the ailments of longevity. Younger people, on the other hand, are brought up in a slightly different world of immediacy of information, immediacy of knowledge, and an expectation of immediacy of service, if you like. So it's against some of those changing societal and demographic changes and demands on A&E that I was asked by the Secretary of State to undertake a review of the urgent and emergency care system in January 2013. And the vision at that time was really quite simple. The first thing is that it is clear that we need to provide for our citizens responsive services close to home. The second thing we need to do is to ensure that those people with serious life-threatening conditions are treated in places which have the appropriate expertise to deal with those. There are several steps for getting there. The first is that we need to improve the support that we offer people for self-care. In other bits of their life, people do an awful lot of self-care in the form of online banking, online travel bookings, and in health. We have, in many respects, fallen behind that kind of expectation which exists in other parts of society. The second thing we need to do is ensure that people get the right advice at the right time. And much of that has been focused on improving 111 services, which you all know got off to a bit of a rocky start, but is now much better than it was and is working pretty well in most areas. It is also important that we offer services outside hospital, which are much easier to access and which make it easier for people to attend those services rather than queue in A&E. The next step is that we need to ensure that people with very serious conditions are treated and are seen in centres of expertise. And, of course, the really important thing for achieving all of this is that we need to connect all parts of our urgent and emergency care system together in networks. Now, the strongest drivers for making this work are to ensure that whatever new system we put in place is quite simply intuitive and easy for people to use. At the moment, we don't present the public with a system that is easy and intuitive. So, for example, providing responsive services outside hospital to try and discourage people from wanting to queue in A&E means that we need to offer consistent same-day services 7 days a week to general practitioners, to primary care, to community services, to local mental health trusts and organizations. We need to harness the skills of community pharmacists in a way that we haven't done before, and we need to turn our ambulance services into more like mobile treatment facilities. We published our progress update on NHS choices in August 2014, which covers a bit more detail than I've given today. So I think, Chris, I'll stop my remarks at that point and wish you luck in your deliberations today, because we're really interested in what comes out of here.
Thank you.
Thanks very much.